All right. Well, happy March 1st, everyone. Kind of hard to believe. But this is our COVID update. Thank you all for joining. And so we'll start off with the good news that the New Mexico map is all green. I can't think of the last time that happened. This is the map that shows both case counts and hospitalizations. So things are overall looking good. Now, of course, we all still know people who are getting COVID and testing for COVID and having symptoms. Um, Although I think that's uh, getting better. But again, home tests do not go into these map metrics. But I think the key thing about that other map is that it does take into account hospitalization. So it's nice to see that those are down. On the community transmission map, also a mishmash of colors. Red is high levels of transmission, high case counts and high case positivity. And then blue is low case counts and low positivity. So overall, this map is looking a lot better too. Across the US, there's still about 50% of the counties in the US that are in the red color. So, as we've sort of said so many times, like it feels like a little bit of a breather. We're not out of the woods yet. And when I say we're not out of the woods yet, I mean, the yet part is sort of interesting that I still say that because, I think really what we're transitioning or need to be, there's a lot of transitions going on, but one of the transitions is to just thinking about COVID as kind of, part of our lives going forward. This is looking at New Mexico specific case counts, and you can see that our case numbers are down. This is really for a little over a month. We've had in the area of 50 cases per 100,000 people per week in the state. So we've been in a little lull. And again, this is not taking into account home tests. When we look at the variant situation, it's been XBB 0.1, 0.5 for quite some time now. This is really a homegrown variant. It started first noted in the New York City area. And it is an aggressive variant in that it has managed to take over most of the cases across the US. What's interesting now is that there really isn't a new one on the horizon. So we'll see how long XBB 0.1, 0.5 hangs out. There was some talk about the CH 1.1, but it's kind of this, I don't know what color you call it, brownish bar, and it really has stayed kind of a small player in the US. In other parts of the world, it's a little bit of a bigger player. So we'll see what happens. What is interesting, New York City was able to do a study that just got published about XBB in their community. It started showing up in November and December and really showed that there weren't worse outcomes with XBB. We always wonder, like, is this, it is in some ways a more aggressive variant in that it's been able to take over in terms of cases, but does it make people sicker? And what the New York study showed is it doesn't make people sicker. And, that might be partly because lots of people are vaccinated and lots of people have had prior infections, which do provide some protection. But overall, good news. Okay, looking at long COVID, there is more information coming out about long COVID. This study that we're noting here reported that Black and Hispanic individuals are more likely to experience COVID-related symptoms, such as chest pain, diabetes, and shortness of breath, and headaches compared to white patients. I mean, again, long COVID is such a mishmash of symptoms. Sometimes it is just symptoms like feeling tired or feeling a little short of breath. And sometimes it's really talking about some very serious consequences like developing diabetes or having clots in the lung or even things like strokes and heart issues, heart attacks. So it is still when we talk about long COVID, a big bucket of different things that can happen. One of the other nice things or good news in all this is that the Kaiser Family Foundation also did a study, and it seems to show that the amount of long COVID is decreasing. And so again, while there's still a lot of cases and people who get infected multiple times, it looks like perhaps having been infected before or having had an immunization to COVID does seem to be protecting us from quite as much long COVID. So we'll see if over time that continues to be the case, but that was good news. Okay, there are also, I mean, probably everyone's heard about the transition, which is the end of the public health emergency on the federal level. And this will bring a lot of changes to how we respond to COVID, mostly bottom line, kind of less money that will be put towards it. But vaccines will, as long as the federal government has supply of vaccine, then those vaccines will stay free. So the end of the public health emergency will not mean that immediately people have to start paying for vaccine with their insurance or paying out of pocket if they don't have insurance. So we do have a little bit of a buffer. The public health emergency will end on May 11th. That the declaration, and then as long as there's COVID vaccine available in the national stockpile, those will be made free to pharmacists and providers the way they are now. On top of that, Moderna did say that they're committed to still providing their vaccine to people without insurance. That will, even after the public health emergency ends and the stockpile runs out. Interestingly, the Moderna supply of primary series vaccine, that old monovalent, how you start your vaccine series, all the Moderna is going to expire at the beginning of April. So the only Moderna that will be available is that bivalent Moderna. But Moderna does say that they will make all of their vaccines available through a patient assistance program. So that's usually a little bit of paperwork, but oftentimes providers and pharmacists can help people through that. Okay, broadening the picture a little bit, we do have a problem with lower rates of children's vaccines across the state and really across the US. This is looking at New Mexico's rate of measles coverage in kindergartners. So the first MMR, measles, mumps, rubella vaccine is given at 1 year old. And then the next one is given before entering kindergarten, so 4 to 5 years old. And in 2019-2020 year, we had a 97% vax rate. In 2021, it dropped down to 95.7, and now we're under 95. Because measles is such an infectious disease, we really, for community protection, look to have that rate of vaccination at 95% or higher. Higher is always better. So anyway, we have catch-up work to do on immunizations across the board, not just COVID. All right, this is kind of fun. The first COVID and flu combo test that can be done at home did just get approved. It's not really in the market in the US yet. It takes about 30 minutes, but tests for both. It's probably going to be pretty expensive when it first comes out. But I think one of the cool things about the the COVID pandemic, if we're looking for a silver lining, is just the amount of innovation that's happened. Adult vaccines, also an area where we could do better across the board. There are more and more vaccines aimed at providing adults from diseases that affect them, just kind of like your childhood vaccines protect our children. And those, of course, COVID is one of them. Flu shot we're all familiar with. The pneumovax, or the pneumonia shot, or pneumococcal disease is its official name. Shingles is another one that people need protection from. There are some materials that were made and are on the website at this link that have information about adult vaccines. We would love for you to look at those and provide a little feedback about the messaging on them and whether it resonates with you and the people that you talk to. And then the other big transition with the end of the public health emergency is that the federal government is basically, when the federal health emergency ends, then that Medicaid extension is going to stop. So during the whole pandemic, the federal government said, states, you can't kick anyone off of Medicaid. So everyone just got to keep their Medicaid. Well, now we're all really out of practice. You know, back in the day before the pandemic, people really did have to pay attention and renew their Medicaid on a regular basis, and SNAP as well. So starting on March, the public health emergency ends May 11th, but even before that, the Medicaid extension is going to end. So people do need to be on the lookout for information coming from Medicaid about renewing their Medicaid. There are instructions on this at the website and this link here. And then they also are going to send turquoise envelopes reminding people, so don't throw away the turquoise envelopes. Open them up and read them. And then for people who will no longer be eligible for Medicaid, because some people will find that maybe their income went up and they're not eligible for Medicaid, they can go to the Be Well NM website. This is the health insurance exchange, and there are plans that cost as little as $10 a month, and people can get insurance through the health insurance exchange. It usually has a small sign-up window, but the enrollment, they do have a special enrollment period because of all these changes, and it starts now and ends October 31st. So a lot going on in that front. Quick look at flu. Flu's looking much better across the country. We still continue to stand out as a relative hot spot, but that's in New Mexico getting better. This thicker yellow line is our influenza-like illness curve. So you can see it's coming down. We're almost below kind of the baseline. The thicker blue line is the US in general. So you can see we did have a much worse year than most of the US. And then this is looking at influenza vaccination rates this year by age. Well, this year being this flu season. So you can see that our 65 and over group did fairly well with flu, but it's still only at 60%. And then it goes down as, you know, for these younger age groups, which is too bad. It would be nice to see that flu rate higher. All right, thanks. That's all I have today. Thanks for all you do, and I'm happy to answer any questions. I wanted to say one other thing, if there's no questions, about the end of the public health emergency. The other thing that there's a good stockpile of is Paxlovid, the oral medication to treat COVID. So again, we aren't going to suddenly on May 11th have to start paying for Paxlovid if you don't have insurance. There isn't as much information as we would like on this whole transition. I think lots of people are trying to figure things out. So I think this can be an ongoing topic on this call as we learn more information. But I think my take home for this week was really that while the public health emergency does have a firm end date, lots of other things aren't going to change immediately on May 11th.
Thank you. Adrian, do you want to ask your question or
Yeah,
comment?
so I was wondering with the Paxlovid, if you've had COVID twice, I've had reports of them denying the second time for Paxlovid. Is that something?
that is not a rule, or a rule that it's not part of the EUA for Paxlovid. So we do still feel like there's lots of provider resistance to prescribing Paxlovid. And I did want to just mention one other resource, which we're getting up and running through the call center for COVID. So that's the number that, if you haven't memorized by now, 1-855-600-3453, but they can help hook people up with Paxlovid, including now we have a one sole provider who, if you really qualify for Paxlovid but can't get it through your provider because they're too busy or they won't call you back or they don't think you need it, can call in basically does a phone visit and then calls in the prescription. And they're working together. This really got started. I want to give credit to the Poison Control Center. They really started doing this, but they only have pharmacists that are prescribing, and there's a few more rules about pharmacists prescribing Paxlovid. But between the two of them, they usually can get people who qualify. And really the only qualification, you can't be on meds that interfere, that don't work well with Paxlovid, of which there are a few, and you have to be at high risk for a bad outcome from COVID. So if you're 20 and perfectly healthy, that's not really the group that Paxlovid's gonna be recommended for. Sorry for the long answer, Adrian. I hope that answered your question, though.
Yes, thank you.
Thank you. Another question in the chat is, can the Paxlovid be prescribed through that number anywhere in the state? In our rural communities, if someone doesn't already have a PCP, it is hard to get Paxlovid in time.
So yes, you can, anyone in the state can call, and she basically, part of the getting things up and running is she actually has to call in a prescription because the technology to e-prescribe hasn't happened yet, but so I would tell people be armed with the local pharmacy number so that you can, and again, there are some people who are on meds where you can't prescribe Paxlovid, so it's not like a guarantee, but you can talk with her. She'll sort of go through your risks, go through your medicines, go through your medical problems, and then if it's appropriate to prescribe, she'll do either Paxlovid or Molnupiravir. We'll call it into your local pharmacy and you can go pick it up there. So she can call into any pharmacy in New Mexico.
Dr. Durham, would you mind putting that number in the chat for everyone?
Absolutely. Oops. And option 9 for Spanish. And option 2 or 3 for. So this, I'll just give one other thing about 1-855. About this program is that she does not work full time on this project. So oftentimes the message the person will get is, we'll do a little screening to make sure you still qualify, that it's not too many days haven't gone by or whatever. And then she'll call you back later on in the evening. So it's not like, just so people's expectations are clear, not just kind of an instant, like I call and I get my Paxlovid, but I think it is it will help for some of these situations we're talking about.
Are there any other questions?
Sí. Quería preguntarle a la doctora, para los pacientes que llegan nuevos a la clínica para ponerse la primera dosis, nosotros no la tenemos, nomás tenemos la bivalente moderna. pero nos preguntan que si es recomendable ponerse la primera y segunda dosis si ya viene la bivalente como vacuna primaria. ¿Qué les podemos decir a ellos? ¿Que se esperen?
So if you've had no doses of vaccine, you still do have to start with a primary series of COVID vaccine. So a couple things on that. Johnson & Johnson basically is not an option anymore. Most of it expired. There's a few vials hanging out, but it's on its way out and it's not going to get renewed. Moderna, like we said, is most of that stock is going to expire at early April. So pretty soon, Moderna is not going to be a choice for that first 2 shots that you need. So basically, people can get Novavax and they can get Pfizer, and Pfizer is going to be by far the most available. And then if by some reason you let's say you started with 1 dose of Moderna and then just never went and got the second dose, it's once the Moderna expires, it is okay to mix and match even that primary series. So you'd get a second one, then a second dose that could be Pfizer. Once you've had those 2 doses, then you can wait 2 months and get a bivalent. Now, what we were hoping is that we could just give bivalent for everything, but FDA is talking about it, CDC is talking about it. That decision hasn't been made. So we're still stuck with giving the original vaccine or monovalent, sometimes it gets called, or primary series vaccine, the old fashioned, the stuff we gave at the very beginning. You still have to get 2 doses of that before you can get the bivalent. Does that answer the question?
Sí.
Okay.
Thank you so much. Yes.
There are right now 11 different vials, and that's not even counting Novavax and J&J, 11 different vials of vaccine. It's super complicated, and that is why I think everyone was hoping that FDA and CDC would really try to simplify the recommendations, because it's really confusing to message. It's confusing for providers. It takes lots of space in your fridge to keep all those different vaccines. I think it's coming, but for now, we have the 11 to deal with.
Yes, Brenda?
Hi, I logged on a little bit late, so is this Q&A time? Is that okay?
Yep.
Okay, all right. So I wanted to ask Dr. Durham about, people who are 65 and over, who, let's see, so have an aunt and uncle 65 and over, and they got COVID in November. I'm sorry, December, like right before Christmas. Are they eligible for a shot now, or do they need to wait a little bit longer? And they've had all their series. I mean, they've had all their shots, except for the new, of course, the bivalent. But they have everything before that.
Okay, so if they haven't had the bivalent, then they are still eligible for the bivalent, and that you really can give that anytime after the COVID illness has resolved.
Oh.
But I think given, I would say my recommendation, so the rule is you can give it anytime after, but even the rule is starting to say, hey, think about waiting 3 months after infection, because infection does boost your antibody levels and it does give you protection for a while. So my recommendation would be, unless they're traveling somewhere and they really want that kind of extra protection of a fresh vaccine,
Right.
you know, wait 3 months from the end of the illness to their bivalent booster.
Okay.
But
Fantastic.
anytime that's kind of convenient in that 2 to 3 month range.
Perfect. Thank you so much.
All right.
Any other questions for Dr. Durham? Great. Well, thank you
Put
so
the
much.
number back in the chat. Sorry, somehow I had an individual's name there. So thank you for pointing that out. And yeah. Cool. Well, nice to see you all. Thanks for all the great questions. And we'll see you in 2 weeks.
Yes, this
All
time
right.
in 2 weeks.
This time in 2 weeks, right? All right.
Thank you
Take
so
care,
much.
everyone.
Bye.
Bye.
I will introduce myself. My name is Daniela. I am on the health equity team at CHWI UNM. And I am the program manager of our sort of behavioral health piece of the health equity program. And okay. Can everybody see my screen?
No,
No.
Daniela.
Okay, let's see. Try that. How about that?
Yes, we can.
Yes.
We can see the screen.
Perfect.
Yeah.
Lots of good thumbs up. Wonderful. Cool. So today I'm just going to be going over some behavioral health models. Just 3 of them. There's a lot, but we're just going to be talking about 3 today. And I think that there's sort of helpful ways to kind of frame and think about the work that we're all doing around behavioral and mental health. All right. So yeah, there's many different ways to look at behavioral and mental health, and these are just a couple of them. So the 3 that we're going to be talking about today are the medical model, the psychosocial model, sometimes called the behavioral model, but we'll call it the psychosocial model, and the social model. And I just want to apologize. This is a word-heavy PowerPoint, so bear with me. I didn't add very many cute pictures, so apologies. So the medical model. So the medical model is sort of the school of thought that I think we sort of hear about a lot and is sort of definitely a framework that sort of Western healthcare is often looked at through. But it explains illness, and in this case, specifically mental illness, as the result of a physical cause. So it's the way that mental and emotional issues are related to biological causes and problems. It also suggests that the way that we identify and treat illness is through the sort of standard accepted procedure that we think about when we think of medicine. So that is, you identify what's going on, you treat it, you monitor it, you use tests, symptom descriptions, prognosis. So like what's the sort of course of the illness or the disease, and then what type of treatment is there to cure it or to treat the symptoms. So the way that the medical model looks at mental health and mental illness is that it's a result of brain abnormalities, genetic predispositions, and biochemical irregularities. So some examples of this are that depression is caused by a chemical imbalance in your brain, right? That's like a biological cause. Another example is if the patient's symptoms are hallucinations, delusions, or disorganized speech, the clinician will likely diagnose the client or the patient with schizophrenia. So it's looking at those symptoms. What do they add up to? Here's the diagnosis. What are the treatments? And so then also an example of the medical model is once a patient has been diagnosed, then the psychiatrist in the case of mental health, but the clinician will then decide on the best treatment. So there are strengths and sort of criticisms of all of these models. So some of the strengths of the medical model are that it tends to be objective and it follows empirical sort of information. So it's based on observable facts, and it's sort of a very objective way of diagnosing and treating mental illness. It doesn't really include a lot of sort of like personal opinions, which, you know, can potentially be like stigmas or, you know, personal feelings about what's going on with the patient. Also, research does show a genetic and biological component to mental illness. So that is taken into consideration in the medical model, is that research does support that. It also has like practical real life applications. So it describes like diagnosis, like the standards for diagnoses, right? Like if you fulfill these types of symptoms, it leads to this diagnosis. So it's really applicable, it's easy to follow, and it outlines treatments. And like, you know, many of the treatments for mental illness are widely available, pretty sort of straightforward. You know, if like you have this diagnosis, then these are the treatments that are recommended, and many of the treatments are very effective. So treatments, you know, are, you know, they can be medication, they can be therapeutic, and they can be like a combination of that. So then criticisms of the medical model is that it focuses heavily on disability and impairment rather than the sort of strengths and abilities of the patient or the client. And it can sometimes encourage paternalism within medicine rather than the empowerment of the patient. So in sort of according to the medical model, the clinician or the doctor is the one who determines what's going on and then determines the correct treatment options. It doesn't really come from the patient typically, according to this model. And it also sort of suggests that there's not really free will over mental illness or behavioral health issues. So it sort of says that, you know, illness is caused by genetics and biological reasons, and that we as individuals don't really have the ability to sort of change that. So it's kind of the nature versus nurture question, right? Which is that genetics, so nature is the root of mental illness, and nurture, like your environment, is not taken into consideration in this model. So we're going to juxtapose and compare the medical model to the biopsychosocial model. So according to the biopsychosocial model, mental health is made up of multiple factors, including biological, like in the medical model, right? Genetics, brain chemistry, maybe brain damage, biological things, as well as social. So your family, your traumas that you might have experienced, things that are stressing you out, life experiences, including childhood experiences, and then also psychological. So psychological is how we interpret events, right? So psychological can be beliefs, emotions, coping skills, behavior, stuff like that. So according to the biopsychosocial model, a combination of all of those things are what causes mental health disorders, and it's complicated, it's complex, and it's varied depending on each person, it's individualized. So biological factors do play a role, but they're not the only thing. So here is sort of a visual model of the psychosocial model. So as you can see, there's the biological, the social, the psychological, they all are combined to result in mental health. So also, like with the medical model, there's strengths and sort of criticisms of the biopsychosocial model. So one of the strengths is that it is considered to be much more patient-centric. So patients have a lot more sort of autonomy and participation in their care in the biopsychosocial model. It also focuses, because it focuses on psychological aspects, so the individual's interpretation and behavior around events, it can really empower people and give them a sense of hope that things can be different, they can be changed. And it suggests that the individual, as well as their support network, their community, all has a role in the well-being of people and their mental health. I think sort of an example of that is that because, things like family and community and work and religion are all sort of taken into consideration, it just indicates that those things are also important aspects of mental health. And another strength is that the biopsychosocial model can help providers and clinicians to understand the different components of their patient's health, and it encourages multidisciplinary approaches. So because the clinician is not just asking the patient, what are your symptoms? They're also asking, tell me about your life. What do you do for work? What's your family like? They're taking all of those different pieces into consideration. And because it's also decisions are not being made only by a psychiatrist in the case of mental health, it's maybe sort of decisions in the patient's care are being made in a multidisciplinary way by maybe a social worker, a community health worker, a psychiatrist, and maybe a nurse, right? So it's multidisciplinary. There are some criticisms of the biopsychosocial model as well. So one of them is that it's unclear. So unlike the medical model, which is very clear, right? It has like these symptoms lead to this diagnosis, lead to that treatment. Biopsychosocial model is not like that. It has many variables, and sort of one of the criticisms is that there are maybe too many variables, and it's difficult to determine sort of which variables are more important and which are less important. Is someone's job more important in their mental health than their childhood with their family? Or are they both equally important? What about the biological piece? They have no coping skills. Is that important? So it's not very cut and dry. And because there is all of that room for subjectivity, it can potentially lead to stigma and, around, because it is much more subjective and less objective. So here is a case scenario that I will just go through with you to sort of compare the two different models when looking at this case example. So Joe is a 60-year-old man with high blood pressure and a long history of smoking. It is snowing, and his wife's younger brother, who he does not have a good relationship with, is visiting for the week. Joe's wife complains that Joe never shovels the snow, and she shoots a knowing glance to her brother. Joe feels in this moment that his masculinity is being questioned, and he angrily grabs a shovel and begins to vigorously clear the snow from the driveway. 15 minutes later, he has a heart attack and he passes away. So how can we look at this case scenario from both the medical model and the biopsychosocial model? So according to the medical model, Joe's death was caused by the combination of his strenuous physical activity combined with his high risk factors for a heart attack: his age, high blood pressure, long history of smoking. Those things make him higher risk. And so the combination of those biological factors caused him to have a heart attack. Now, according to the biopsychosocial model, Joe's pride was threatened. and he was maybe unaware of his high risk factors for heart attack, or maybe he was kind of in denial about it. His sort of maybe the role of masculinity in his life culturally, and his complicated relationship with his brother-in-law really put him in the position where he pushed himself physically in that moment. Whether he knew he was doing it or not, he was pushing himself. The snowstorm and the fact that their driveway was full of snow provided the context for the action of him shoveling. And so all of these things in combination directly related to Joe's heart attack. So the third model that we're going to be talking about today, and we will have, time for discussion and questions at the end. So don't worry. I see little chats beeping, but I can't multitask, apologies. So the third model we're going to look at is the social model. So this is a slightly different model. The social model was developed by disability activists in the 60s and 70s. And it's a model of disability, which can be physical disability or, mental illness disability. But it says that people are disabled by barriers in society. For example, buildings not having a ramp for wheelchair access, or accessible toilets, or people's stigma toward disability. And it's so that the disability is structural and social. It's not on the person who is quote unquote disabled. So it is, the social model of disability is different from the medical model of disability, because in the medical model of disability, disability is seen as an individual problem that requires a medical intervention. But the social model of disability focuses on eliminating the structural and social barriers, and in order so that, and says that disability is not an individual problem. It's a social and structural problem. And this is sort of an important model because many people who are disabled feel that their disability is not something that needs to be cured, but an integral part of their identity. And this also includes many people with mental illnesses or mental or behavioral health diagnoses. So we're going to keep talking about it. So we are going to do another case scenario, and we're going to look at it from both the social model perspective as well as the medical model perspective. So in this case scenario, Sophia was born with muscular dystrophy. She uses a wheelchair. She lives alone in a house that is completely wheelchair accessible. She can do everything that she needs independently. She drives an outfitted vehicle that accommodates her wheelchair. Sophia goes to a new grocery store one day, but there are only stairs to enter the building. She can see inside the door of the store, and the aisles are very narrow and the items are stacked up high. So from the medical model, this case scenario says that if a person is unable to climb stairs, the focus of the medical model is making the individual physically able to climb stairs. And sort of, it also makes it sort of like the issue is on the individual. How can we make it possible for you to climb these stairs? Now, according to the social model, it tries to make the stair climbing unnecessary. So making society adapt to accommodate Sophia's needs. So in this case, the store would have a ramp and wide aisles to accommodate a wheelchair, and items on the shelves would be at a lower level so people in wheelchairs could reach them comfortably. So according to the social model, in this scenario, Sophia is disabled only in the respect of climbing the stairs, but the disability is negligible and no longer disabling in a scenario where the building is accessible and she can do her shopping. Also in this scenario, Sophia's home and vehicle are completely accessible to her, and therefore her disability is negligible. She is not disabled in her home. So here's a little image. According to the medical model, her impairment is the problem, her disability. They should cure her or give her prosthetics, saying about the person in the wheelchair. And then according to the social model, the stairs are the problem, they should build a ramp. So it's looking at it rather medicalized and individual versus sort of social and structural. So these models are not mutually exclusive, and they can and they do coexist. There are, like we talked about, there are strengths and sort of weaknesses and criticisms of all of them. And a model is not an absolute truth. It's just like a tool, like all the tools in your toolbox for helping patients and clients. And there are also many other models that sort of frame mental health and behavioral health and disability in different ways. And I think there's, you know, positives and negatives to all of them. So we are going to do we're going to sort of take a moment, and I have 3 questions here. So we'll do each question one at a time, and we'll give everybody sort of a moment and to think about it and develop your response. And then if you could put your answers in the chat, or if you want to speak up, go ahead and raise your hand or do the little hand button. And we will just sort of talk about these questions for a few minutes. So let's do the first one. So the first question is, what resonates for you about these different models? So let's take a moment. Go ahead and put your answer in the chat, or if you want to speak, go ahead and raise your hand, and we'll take a couple minutes. Does anyone want to just share some thoughts about what resonated for you about these models?
I'd like to say something.
Please.
I can't get my little hand to raise.
No worries.
This is Ife Machkia Gaston. I resonate with both because I do work in a community that with the long-term care and the waiver, as well as elders in the community, that you have to use both. You can't use one or the other really, because they have certain comorbidities that are causing them to have some psychological issues, but they also have psychosocial things that are causing issues and stresses, or maybe something that's left over from traumas. PTSD, have a few that are veterans, and they certainly weren't that way before the service, but they are now. So that's just my 5 cents on that.
Yeah, thank you so much. Yeah, so in the work that you do, the application of multiple of those models, both of the models, both the psychosocial and the biological, are valuable and important. Thank you.
Yes, ma'am.
Silda. Silda, can you hear me? Ah, there we go.
Sí, a mí me resonó mucho, ¿verdad? La importancia de que los restaurantes y los negocios tengan acceso a una silla de ruedas, ¿verdad? Porque nosotros en una ocasión anduvimos viendo ciertos negocios que no tenían acceso a silla de ruedas, entonces nosotros reportamos algunos de negocios que no tenían acceso para entrar en una silla de ruedas a un baño, porque es muy importante que una persona que pueda ir al baño, ¿verdad? Y entrar fácilmente con su silla de ruedas hasta el baño, que tenga ese acceso. También ayer me topé una persona que le di información acerca del 988, me dijo que ella había tenido un problema muy fuerte con su hijo. Su hijo la quiso golpear, pero ella no le quiso hablar a la policía porque no quería que la policía se llevara a su hija, a su hijo. Entonces le di yo la información del 988, ¿verdad? Y le digo, pues esta línea es muy importante que sepan de esta línea porque pueden tener consejería sin que se meta la policía y lo arreste o algo. Entonces le dio mucho gusto que le haya dado esa información.
Thank you, gracias. I am so sorry. My translation seems not to be working. Lo siento. Sarah, can you help me and with what Silda shared? Oh, I think we've lost Sarah. Silda, gracias.
Thank you.
Sarah, she's here, but we
Oh.
cannot hear you here. You're on mute, Sarah.
Hola,
Okay.
Silda.
Here you
Silda, ¿puedes explicar esto una vez más?
Sí, claro que sí. Le digo que a mí me resonó mucho lo de que los negocios tengan acceso a la silla de ruedas. Nosotros en una ocasión anduvimos trabajando, mirando ciertos negocios que no tenían el acceso. Entonces no tenían la rampa para entrar bien a un restaurante, no cabía una silla de ruedas en el restaurante. Entonces nosotros dijimos de ese restaurante y los hicieron remodelar y poner ese acceso.
Yeah, so Silda's saying how a lot of, sí, ¿está lista? O... Sí, so Renee, Silda's saying how a lot of businesses don't have a wheelchair ramp. And some are adapting that, but some haven't actually gotten around to having a wheelchair ramp. And that's been affecting accessibility as well. So that's been frustrating.
Yeah, absolutely. Thank you, Silda. Thank you, Sarah. Yeah, I feel like, you know, thinking about how the world that we live in is sort of maybe causing disability in that folks are not able to participate in the ways that they want to and need to. Thank you. All right, let's, so just really quickly, I have in the chat, yes, I can definitely send out these slides if folks are interested. I will work with Anshul and Liesel to get those out. Brenda.
Oh, hello. Good afternoon. Good to see everyone. I have a question. I'm trying to figure out how to phrase it. So I guess first of all, you know, I tend to find out a little bit more than like your typical state employee because I'm a steward. I'm a union steward, and so sometimes folks, you know, will kind of reach out and say, hey, you know, what can I do, you know, to work better with my coworkers, or that maybe there's a better understanding with some of the issues. And so, you know, and specifically, we're talking about the relationship, the professional relationship between supervisor and employee, where the employee has a family medical leave and it's intermittent due to mental health, you know, concerns. So, however, when it is time for the employee evaluation, how can that employee and the supervisor work together to ensure that, you know, the goals are being are being set fairly, and the expectations of course are being set fairly. You know, especially, you know, with, you know, it's different, you know, when we talk about it, you know, well, you know, like the, you know, the wheelchair example that you were talking about, you know, and then of course this, it's like, you know, so how can you know, these two work together, employee and supervisor, in terms of something that, you know, potentially the employer may not understand. And so how can they be a little bit more flexible? Because it's like, okay, so you have family medical leave, you know, once your family medical leave is over, you know, it's like, yeah, things are going to kind of come back to the usual. It's not like healing from a broken leg or something like that, where things come back to the usual, you know. And so family medical leave for mental health can definitely be long term. So how do we create, you know, this environment where maybe there's, you know, some sort of sympathy, empathy, but still, you know, reaching, you know, and working, you know, and doing what you got to do as an employee. I don't know if that kind of makes sense or not. Because yeah, I've had folks come and like, you know, I feel like I got a low score because, you know, I have intermittent, or sometimes that requires, of course, missing a morning or missing an afternoon here and there, you know, and so now I'm not reliable, or, you know, the supervisor sees me as not flexible. So, you know, how can this social model be applied in terms of, you know, like employers having a maybe better understanding of what that includes?
Yeah, sure. Thank you, Brenda. I mean, I feel like you bring up a lot of really good points and really good sort of questions that I think we as community members, as, you know, workers, employees, supervisors, all sort of should and need to kind of grapple with.
Yeah.
I think that it definitely sort of calls to me, my first sort of thought about that was just like, wow, this just sounds like even more sort of evidence for how important supportive and reflective supervision is, and having those sort of like trusting and strong relationships between supervisors and supervisees, so that supervisees feel comfortable talking to their supervisors about what's going on, and supervisors are able to really meet their team where they're at. I think it also brings up the sort of issue around stigma around mental and behavioral health, and how often it's not seen, especially in workplaces, as the same as a, you know, a physical ailment. And right, that's stigma related. So I think that is also a really important point you bring up. And then I love that you sort of also brought in, like, how can we look at this through the social model, right? Like if our places of work were truly accessible and really provided the support that people needed, would it be a problem, right? So yeah, I think you bring up a lot of really good points. Thank you so much, Brenda.
Yeah, no, thank you for that. Yeah, it's a complicated question, you know, scenario for sure, because you know, I think employees feel that, you know, because it's not something, you know, outright visible, but at the same time they're having challenges, you know, with whatever work expectations. They get docked on their evaluation, but it's like, wait, like, no, like, it's, you know, let's work on something together.
Yeah,
Well, thank
absolutely.
You so much. I appreciate
Yeah, thank you, Brenda. And we have a couple of just great sort of thoughts that people have shared in the slides, or in the chat, sorry. Someone said, what resonates for me is that there are always solutions. I think there will always be issues with groups with sort of health conditions and health challenges, but that it all needs to sort of work in tandem together. So yeah, thank you. Somebody said, I like the multidisciplinary approach. So thank you. So I'm going to wrap up in just a moment so that there can be 15 minutes of mindfulness. But I do sort of, I know the slide is still up, so you can sort of look at these questions, but I do think that these are sort of important things that we all, you know, can sort of be thinking about in terms of our work and our communities and our families and clients and stuff like that. So thank you all so much. It has been a pleasure to get to sort of geek out on this with you all. So thank you so much.